We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, academic session with Malanadu, Cochin, Angamaly, Thrissur and Palakkad societies of KFOG. So it's my privilege to introduce the convener of today's webinar, Dr. Shyama ma'am. Ma'am is the Chief Consultant in Fetal Medicine at Ambadi Scans Thrissur, Secretary of Thrissur OBGYN Society. I welcome you, ma'am. And it's my pleasure to introduce Dr. Atulya Shajan, ma'am. Ma'am is the consultant at Department of Reproductive Medicine and Surgery, CIMAR Thrissur, Kerala. So I
Thank you.
welcome you, ma'am, and I hand over the session to you.
Hello, a very good evening, everyone. I welcome you all to the 30th episode of our webinar series, proudly conducted by AMOG's Emergency Obstetrics Committee with the Malanadu, Cochin, Angamaly, Thrissur, and Palakkad societies of KFOG. We are delighted to have you all join us today for a very insightful session on emergency obstetric practices. This initiative is a brainchild of Dr. Sneha Boyar, Madam, the esteemed chairperson of the Emergency Obstetric Committee, whose vision and dedication have made this webinar series possible for us. We look forward to an engaging and informative session ahead. As we move forward with our program, please join us for the ceremonial lamp lighting, symbolizing the illumination of knowledge and the start of our inspiring event. It is my great pleasure to introduce Dr. Sneha Boyar, Madam, a distinguished obstetrician and gynecologist whose accomplishments span an impressive area of awards and contribution. Just to name a few, she has bagged the International MS Signature Award for Phenomenal Leadership, Dr. S.N. Malhotra Individual National Award for Rural Obstetrics, Dr. Duru Shah Distinguished Community Service National Individual Award, Champion of Foxy Award, Dhira Award, Dr. Anandibai Joshi State Award from the Government of Maharashtra, the Lokmat Healthcare Excellence Award. Madam's contributions to academic and professional communities include more than more than 3,300 publications, more than over 100 panels. She's authored over 30 chapters. She's also served distinguished leadership roles as Foxy Breast Committee Chairperson, National Adolescent Trainer. She's certified by WHO and FPAI, National Expert for UNICEF, Peer Reviewer for Jogi, and her current positions include AMOG's Chairperson, Medical Disorders Committee, AMOG's Chairperson for Emergency Obstetrics Committee. She is actively involved with the Mission Pink Health. She is a convener for the PCPNDT and is a member of the SAFOG Working Group on Breastfeeding. Over to you, ma'am.
Thank you so much, Dr. Atulya, for that kind and generous introduction, I would say. A very good evening to one and all. My respects and regards to all the seniors here, with special mention to, of course, Dr. Kunju Moideen, the president of KFOG, secretary, our dear friend, Dr. Subhash Malya, and of course, the chief guest for today's program, Dr. Jaideep Tank. We just hope to him to join in a while, and of course, Dr. J.B. Sharma, the esteemed professor from AIIMS Delhi, and of course, the past committee chairperson of Urogynec Committee, Foxy, and Dr. Sathi Murray. Madam, my respect and regards to you. I welcome all of you, the distinguished luminaries, and of course, the speakers for today's program, our dear friend, Dr. Neena Malhotra, the professor and head of Department of AIIMS Delhi, who will be speaking on prediction of eclampsia, and Dr. Pramila Menon. Madam will be speaking on the management of hypertensive disorders of pregnancy. Of course, we are fortunate enough to have the distinguished chairperson, Madam Gracie Thomas, and Madam Agnes Matthew, Dr. Emmy Globin, and Globin and Elizabeth Jacob. Of course, the senior Madam Radhamani and Ambujam. Madam, we are very proud to have you and, of course, have your precious words as well. So the panel discussion, I will be moderating on antepartum hemorrhage. It will be a very practical case-based discussion. And of course, we are very thankful to all the esteemed panelists from KFOG, that is Dr. Chitra, Dr. Dipti Nair, Dr. Raji Raj, Dr. Madhu Ranjini, and of course, my friends from all over India, Dr. Archana Dwivedi, Dr. Sejal Naik, and Dr. Brajbala Tiwari. I'm very thankful to Dr. Shama, who is the convener of today's program, and of course, Dr. Atulya, who has done all the hard work to organize this program and bring all of us together here. So thank you so much, all of you, for accepting the invitation and for pressing the program. I would like to look forward for a very great academic feast. And with this, I would take this opportunity now to introduce our guest of honor today, because Dr. Jaideep Tank, I think, is not able to join still. If at all, can you just make sure Sahiti can be see Dr. Jaideep Tank join?
Yes, ma'am. Yes, ma'am. I'll inform you.
Okay, thank you so much. So we move ahead with the introduction of guest of honor, Dr. J.B. Sharma. I have already said, sir is a professor at AIIMS Delhi, and of course the past committee chairperson of Urogynec Committee, FOXY, and we have worked together as co-chairpersons. Sir is the proud recipient of Dr. B.C. Rai Award by the Honorable President of India in 2015, and of course he has 350 plus publications in the index and non-index journal. He's the author of textbook of obstetrics and midwifery and gynecological nursing. He has edited 2 books and written 5 chapters in John Sturt's Progress in Obstetrics and Gynecology, published in UK, and lots of accolades and credentials, I'm sure, which is not mentioned here. So over to you, sir, for your precious words of guidance.
Thank you very much, Sneha Bhuer, madam. It has been a real pleasure. We have been, chairperson together, and Dr. Sneha Bhuer is so affectionate. Like everyone respects her and regard. And I wish you all the best, madam. Our full support wholehearted to you. And I request everyone to, vote for ma'am and support her in her endeavors. And I'm really indebted that she has been doing so much academic work, so many webinars, so many conferences, and she has traveled almost whole country, all places, every state, almost cities. So really, you're it is so much. I tell everyone that if you want to, do anything, do like Dr. Sneha. We do with such passion. And I'm so happy that the topic you have chosen for today's this thing, they are so appropriate, because preeclampsia, in spite of it having so much maternal and perinatal mortality and morbidity, and still the prevalence remains high. So why it is so? So it is basically, can we predict preeclampsia? Traditional answer used to be no, but now newer methods have become available, PIGF and lot of other biochemical method and ultrasound Doppler studies. So the initial results appear to be promising. So we'll have that discussion today. I am very happy that Dr. Sneha has collected a galaxy of people, including Professor Neena Malhotra from our AIIMS, who is our HOD, and a lot of other speakers. And I'm so happy to see Kerala Society so active, and they are so always, I'm always scared of, madam, don't mind it, Dr. Sneha, but of South Indian people, they are so much more intelligent than North and West Indian people, no? Full of these things. So I'm really impressed that all of them are there with their full presence. And I wish this conference a great success, and best of luck to Dr. Sneha for her election, and to today's conference for its grand success. Thank you, madam.
Thank you so much, sir. Thank you so much for all your blessings and best wishes. And of course, I too agree with you, sir. The South Indian braids are to the next level.
Yes.
That's the very reason we are also passionate, and we're trying to and trying to learn something from them.
Absolutely.
So thank you so much once again. I welcome Dr. Neena Malhotra also, and I can see Dr. Neena, if you can please put on your video, and I invite you. Yes, Dr. Neena? No, I don't think she's active, though she has joined. So I just take this opportunity to introduce our guest of honor, Madam Sati Murray. Dr. Sati Murray, she's the professor, Department of Obstetrics, Government Medical College, Kottayam. She is the Vice President of KFOG, the Scientific Coordinator of RCOG Kerala Chapter, and of course, the State Coordinator of Food and Drugs Committee, FOXI. She is a facilitator of National Medical Council Nodal Center, Faculty Department, Kottayam, Academic Committee Chairperson, KFOG 2018 to 21. She has already served as and past Secretary of Kottayam Obsgynae Society. And Madam's areas of interest are high-risk obstetrics, preventive oncology, and gynae endoscopy. So we are very eager to listen to you, Madam. Over to you for your precious words.
Thank you, Dr. Sneha Buyar, Madam, and also Dr. Shama Devadasan for inviting me, for giving me a chance to speak here, to be here and share the stage with JB Sharma sir, such prestigious guest of honor. Thank you for the opportunity. And first of all, I really appreciate all the efforts of Sneha Buyar, Madam, for conducting all these academic activities all round, and also coordinating this time with Kerala of the member societies of Kerala Federation of Obstetrics and Gynecology. And you have chosen, as Sir said, all the very relevant topics on our day-to-day practice. And hypertension and obstetric hemorrhage, both are important causes of maternal morbidity and mortality. And so we have to find out ways to put a check on that. And this discussion, I hope this webinar, we have got, you have also robbed in great speakers, eminent speakers, and also the panel members, and expecting good discussion and good take-home points that evolve from this meeting, and wishing this webinar a grand success. And also you, Madam, for a great success for the upcoming.
Thank you so much. That means a lot to me. And of course, Dr. Nina, I have welcomed you already. And in fact, Dr. Nina.
Yeah, hi, good evening.
Yeah, hi.
I am sorry for some net issues. I'm connected from my phone, Dr. Sneha. I
No
apologize for this, but I am so happy to be here. It's indeed a pleasure and honor to be part of this very, very interesting webinar, which has been organized by the Kerala Society. Thanks to Dr. Kunju Moideen, Dr. Subhash Malaya, and of course, Dr. Sharma to come here for this occasion. Do you want me to start the lecture, or can you go in for the next lecture before I set in my things? Because let me set my laptop so that the second lecture can come before mine. Meanwhile, I'll on this. You allow me?
Yeah, definitely. You need that time, and I would request Madam Pramila Menon to, if you can please accept our request to go ahead with the first talk. And with this, I thank all the luminaries who have gathered here. I can see, I have already thanked and welcomed all of you. So once again, I with the blessings of God Almighty and the respected seniors, we go ahead with our academic session. And I thank all of you once again. And over to you, Dr. Atulya, for further proceedings, and over to you for academic session.
Thank you, Madam. So we'll be first moving on to our second session. And as chairpersons, we have Dr. Emmy Globin and Dr. Elizabeth Jacob. Dr. Emmy Globin is a gynecologist and infertility specialist at the Government Women and Children Hospital, Palakkad. She's a president of the Palakkad Obstetric and Gynecological Society. And Dr. Elizabeth Jacob is a HOD and senior consultant, Apollo Edlux Hospital, Angamaly, and she's the vice president of the Angamaly ONG Society. I request Dr. Emmy Globin to kindly introduce our speaker for the day, the second session. Dr. Emmy.
Hello, good evening. Am I audible?
Yes, yeah.
First of all, let me thank all the organizers for giving me a chance to preside over this. Let me introduce Dr. Pramila, who is my mentor. She is a professor at Amla Institute of Medical Science, Thrissur, Kerala. She is the immediate past secretary of Thrissur OBG Society and past editor and past treasurer, KFOG. And she is the winner of Kamini Rao or H. Award in 2017, Yuva All-Rounder and Yuva Foxy 2016, and her special interests are gynec oncology and high-risk obstetrics. Without my schedule, let me invite her to start with the talk.
Thank you, Emmy, for that introduction. I hope I am audible.
Yes, ma'am.
Yeah. Actually, I'm really down with headache, and I'm really feeling very low. So please excuse me if my voice breaks in between. Shall I share my screen?
Yes.
Yes, ma'am.
Yeah, we can see yours. Yeah.
Okay. So thank you, Sneha Madam. First of all the best for your upcoming candidateship. And yes, we are all with you. And thank you.
Thank you so much.
And thank you, Shyama, for giving me this opportunity. And even though my topic was management of hypertensive disorders of pregnancy, I think in 18 minutes, it will be injustice if I take the whole of hypertensive disorders. So I thought we will stick to the main things, that is preeclampsia and eclampsia management. So I am sure all of you are familiar with the confidential review of maternal death that has been happening in Kerala. And this is our observations of last decade. From in the last decade, what we have observed. And this is like a Bible to all of us, actually, this book. And I am really happy to be a part of the editorial team of this book. And if you go through this book, you can see that in the last decade, in the last 10 years, we had around 1,076 maternal deaths, out of which around 10%, that is around 106 cases, were due to hypertensive disorders of pregnancy. So that itself tells us in a state where, in a state like Kerala, where people go for proper antenatal checkup, every facility is there. Still, if you have got this much deaths from happening from hypertensive disorders, that is something which is really alarming. And if you look the trend from 2004 onwards, you can see that almost always just behind PPH, the reason for maternal mortality has been hypertensive disorders, except for few years where sepsis has overtaken it. And if you further look at the categories, we can see that most of these people either belong to preeclampsia or eclampsia or postpartum eclampsia, antepartum or postpartum eclampsia. But that doesn't mean that they all died due to that particular reason. Actually, if you further split into the reasons ultimately why it finally reached to maternal death, you can see that 41%, that is almost 50% of the cases were due to intracerebral hemorrhage, which is really quite shocking because that is the only condition which is actually due to high BP. And that is one thing which we can actually prevent by proper control of BP. That is one thing which we can, if at a proper time, if we intervene, that is one complication which we surely can prevent. So with this background, it is very, let me reiterate the importance of controlling BP and the importance of hypertensive disorders of pregnancy. And when we further actually dwell deeper, we try to find out what might be the reasons why this has happened. So we can see that many of these cases has been referred from peripheral centers, rightly so. And around 27 cases had either underdosing of magnesium sulfate or they didn't receive magnesium sulfate at all. And 12 cases, there was a definite delay in controlling severe hypertension. So these two aspects are the most, I would say, these are the cornerstones in management of any hypertensive disorder in pregnancy. So again, whenever we fail in these cornerstones, naturally we lose a mother. So let me tell you a scenario. This is a real life scenario which has happened, which has been there in that book. A 34-year-old primary gravida who is 34 weeks pregnant, she went to a local hospital with headache and vomiting. At that time, she had a BP of 160/100. And from there, she was referred to the higher center immediately. When she reached the higher center, the BP was around 160/110. She was immediately given magnesium sulfate and then followed by labetalol. But immediately she went into seizure. She became unresponsive. Emergency cesarean section was done. The baby could be saved, but mother went into coma. And a CT then showed she had massive intracranial hemorrhage and the patient succumbed. So I would say we have lost the patient at two settings actually, or actually at three settings, because after this, madam is going to talk about preventive aspects of preeclampsia. So actually, if we had thought about that aspect, we could have sometimes we might have been able to prevent a preeclampsia happening. That's another story. But suppose the patient, when she reached in the peripheral center with a headache and vomiting and 160/100 BP, before referring the patient, if somebody had given at least a loading dose of magnesium sulfate and a labetalol IV, if possible, or at least oral nifedipine to something to control BP, then this may have been prevented. Similarly, when the patient reached a higher center with a BP of 160/110, yes, you are justified in giving both magnesium sulfate and labetalol. But when we actually look back, nobody dies due to eclampsia as such. Everyone dies due to intracerebral hemorrhage. So whenever you have got a patient with a very high BP with impending symptoms, yes, it is important to give magnesium sulfate, but it is also very important to control the BP. I would say the order should have been different. You should have given labetalol first to control the hypertension, followed by magnesium sulfate. Okay. So with this thought, let us just quickly go through the common problems which we face. So we are all familiar with the current classification of gestational hypertension. Then we don't call nowadays mild and severe preeclampsia. We call it as preeclampsia with and without severe features. Because when we say mild, it feels like it is something really okay. So we tend to be a little relaxed. So instead of that, don't use the term mild preeclampsia. We use the term preeclampsia without severe features. So now everyone knows that we all know 140/90 has to be the cutoff. I think Kerala was the first state where I think from 2008 onwards, much before where other people started, even NICE has now accepted that 140/90 should be the cutoff. We were starting to treat patients with 140/90 itself, not 150/100. And because of our review of maternal deaths, we had an idea that 140/90 should be the cutoff. And so any persistently BP having 140/90, yes, you have to start treating them. And the target should be kept just below that. That is around 130/85 or 135/85. You need not try to reduce the BP too much, because if you reduce the BP too much, that is actually going to impair the blood flow to the baby, and the baby can land up with a UTR. And depending upon the level of BP and the period of gestation, we all know different drugs are available, starting from methyl dopa, nifedipine, and labetalol. But what I want to tell important is, it is very important to check BP at every visit. Yes, we all check BP, but who checks the BP? Many times it's the A&M staff who is checking the BP. So it's mandatory that you spend some time with them, teach them how to check the BP properly in the sitting position, with the BP pattern at the level of the heart, and correctors 5 sound to be taken. So those things they have to be told specifically. Not only that, they have to be told that anything over 140/90 is important, because many times what we have seen is they would have recorded the BP as 160/100, and the patient will be sitting in the outside the OPD for 4 hours to see us. So that should not happen. So it is very important to tell them, once you get a BP 140/90 more, immediately bring them into the OPD. Don't make them wait outside. And it is also very important to check frequent urine albumin, because that is something which can tell us that this patient is likely to go into preeclampsia. So in the first and second trimester, at least once you have to do a urine albumin. From 34 weeks onwards, it is ideal that you do urine albumin at each visit. And when you do urine albumin, it's not mandatory that you send them to the lab and do the urine albumin. You can always take the help of the dipstick, and patient herself can do that from the nearby toilet. So I'm not going into the details of antihypertensives. I don't think methyl dopa we all used to use, but I'm not sure whether anybody is getting this nowadays. We don't get this, hence we are not using. Then nifedipine, yes, it's a good drug. It will start acting within 5 to 10 minutes. And the advantage is that it doesn't reduce the blood flow to the uterus. But the problem which we have felt is when you give nifedipine, especially in patients with more severe preeclampsia, nifedipine itself can produce some amount of headache and problems, which can actually sometimes confuse us whether this is impending symptom or not. The other drug which we commonly use nowadays is labetalol. And previously, when we started to use labetalol, people had a confusion whether this having a beta blocking action, whether it can have fetal growth restriction. But now I think we have been using labetalol for so many years, and we are not seeing FGR as a result of labetalol, unless you reduce the BP drastically. But It is a drug which can produce bronchoconstriction. So you should be careful when you are using in severe asthmatics. And all these patients whom you in the OPD, once you detect that the BP is 140/90, you can ask them to take some rest and repeat the BP after some time. But meanwhile, it is mandatory that you do a basic PIH profile. Previously, when we were students and postgraduates, we all used to do only urine protein. And it was a dictum that if the urine protein is negative, you don't do any further test. But now we know that the definition of preeclampsia itself has changed. It's not presence of proteinuria. It's proteinuria or any end organ damage is considered as preeclampsia. So, and we get many times we get patients who go into health syndrome without having any proteinuria. So it's mandatory that you at least do a baseline proper PIH profile. And if the urine protein is positive, you need not repeat it every now and then, because once it is positive, it is positive. There is no need to further check it every day or every instead of 24-hour urine protein, nowadays we do urine protein creatinine ratio, and a value more than 0.3 or 30 milligram per millimole is considered as significant. And if these your platelets are decreasing or the liver functions are showing abnormal report, then you can think about doing a coagulation profile also. Definitely, you have to look at the fetal monitoring also. So once the BP is well controlled and the investigations are normal, there is no IUGR, it's just a gestational hypertension or a preeclampsia without a severe feature, then you may be able to send her home, and you can send her home and ask her to come back every week or 2 weekly and repeat these investigations at least 2 weeks. If it is preeclampsia without severe features, we might have to repeat it every week, but at least 2 weekly, you have to repeat the minimum investigations has to be repeated. And in a setting where the facility is available, you can also use PLGF, which will tell us whether the patient is likely to go into severe preeclampsia in the next 2 weeks. Okay. And all these patients, that is gestational hypertension or preeclampsia without severe features, need to be terminated by completed 37 weeks. There is no question of continuing beyond that, because the only reason we are continuing is for the baby's sake. So once it is beyond 37 weeks, it's time to terminate the pregnancy. Many times, those patients who have been waited further after 38 and up to 39 weeks, they are the ones who land up in trouble with health syndrome and all. Now, coming to preeclampsia with severe features, so anytime the BP goes above 160, 110, it's considered as severe preeclampsia or preeclampsia with severe features. And if you get such a BP recording, there is no need to wait for 4 hours to repeat the BP. Just repeat it after 15 minutes. If it is persistently 160, 110, it is considered as severe category. And any end organ involvement should be considered as a severe preeclampsia. Here again, you have your target is around 135, 85, or even up to 95 is okay. You have to bring it below 140/90. And for treatment of severe high BPs, then definitely parenteral labetalol is considered to be the drug of choice, because it will start acting within 1 to 2 minutes. But if it is not available, or if you are not in a situation to give it, then you can give nifedipine also. Nifedipine will also act in the next 5 minutes. But never give sublingual nifedipine. Previously, we all used to give sublingual nifedipine, but it is now proven that a sublingual nifedipine can suddenly bring down hypotension and can even precipitate an MI and cause maternal death. And there was a confusion earlier whether to give nifedipine along with magnesium sulfate, but because of the common side effects. But we all have been using it for a long time, and there is no increased risk at all. So this dose, I think all of you are familiar with. Labetalol, we all start with 20 milligram IV, then check the BP after 15 minutes. You can increase the BP to 40, 80, up to a maximum of 220 is okay. IV infusion, I will tell in the next slide. If you're using oral nifedipine, you can give 10 milligram, and you can repeat it even after 45 minutes. Hydralazine, not very commonly used in our part, but if you want, you can give it as a bolus, 5 milligram bolus. But when you're using hydralazine, preloading is little important because it can suddenly produce hypotension. Now, this is one drug or one situation which I have been found to be very useful, that is labetalol giving as infusion, especially in patients who have postpartum or post-cesarean. You might have all noticed patients, severe preeclampsia patients underwent cesarean sections. They will be in the ICU. You will be giving IV labetalol. The BP won't be coming down. Most of the time, we might have to start an NTG drip. But instead of that, giving labetalol infusion will very nicely, it will control the BP. And this is one way to easily calculate how to start the labetalol infusion. So each ampule is 20 milligram. You take such 5 ampules, that will give you 100 milligram. That is 20 ml. In 20 ml, you have got 100 milligram. To that, you add 30 ml of NS. So you got a 50 ml solution in which you have got 100 milligram. So every 10 ml will be containing 20 milligram. So you can start with an infusion pump if it is available at 10 ml per hour. 10 ml per hour will give you 20 milligram per hour. And you can titrate the dose every half hourly up to a maximum of 80 ml per hour. So this is how you give the labetalol infusion. This I have found to be very useful, especially in post-cesarean patients. And hydralazine, I'm not touching much. I think this we already discussed. Now coming to, that's regarding severe preeclampsia. Termination of pregnancy, I will come later. Regarding severe preeclampsia, one more thing you have to think about is preventing an eclampsia happening. So for that, I am sure lots of people will have different regimes. Somebody uses Pritchard regime, somebody uses Sibai regime. So many regimes are there. But in Kerala, we all use KFOG regime. So in this regime, what we do is we give a loading dose of magnesium sulfate, 4 gram IV. And along with that, we also give 4 gram IM. So it's almost like you are a Sibai regime, but extra 4 gram IM is given. And then we will be giving 1 gram per hour infusion for next 24 hours or 24 hours after delivery, whichever is later. And we should be careful to avoid fluid overload. Fluid should be restricted to 75 to 80 ml per hour. And it should be continued throughout the delivery and the cesarean section. And the same dose is being given for prophylactic purpose and for treatment of eclampsia. But if the patient is coming with eclampsia, definitely our priority is in taking care of airway, breathing, and all those things, avoiding injury. And immediately after that, you have to control the BP and give this eclampsia prophylaxis or treatment. Magnesium sulfate has to be started. And it is mandatory that whenever you have got a patient with impending symptoms, before you send them somewhere, you have to give this a loading dose of magnesium sulfate. Loading dose never produces toxicity. So you can directly give magnesium sulfate without any doubt. So when you're on magnesium sulfate, I'm sure everyone knows this. What all you want to monitor, your respiratory rate, patellar reflex, and urine output. That has to be monitored, and saturation. And if you are in doubt, you have to stop the infusion, send magnesium levels, and if needed, you might have to use calcium gluconate as an antidote. And as I said earlier, loading dose should be given on admission, irrespective of the urine output or irrespective of the RFT. Only subsequent doses, you have to think about toxicity. Loading dose, nobody has to worry about the toxicity happening. And in a busy situation where you have to deal with so many patients, it is always preferable to have a box like this, an eclampsia box like this, where every essential thing is available at one place. Otherwise, somebody will be running for tubes to collect the blood. Somebody will be running for other things. So it will be a chaos. So it is always preferable to have a box like this within which you have got the labetalol, you have got nifedipine, you have got magnesium sulfate, you have got the antidote, you have got the normal saline, you have got the suction catheter, airway maintaining things, cannulas, syringes, even tapes to stitch it, and even scissors to cut the tape, and a torch with a properly working battery, Euroback, all these things, if you can keep in one box, will be really helpful when you are dealing with such a situation. And when to terminate? Earlier we said if it is gestational hypertension or preeclampsia without severe features, yes, you will terminate at 37 weeks. But if it is severe preeclampsia, the maximum you will continue is up to 34 weeks. And even beyond 34 weeks, you have to terminate. But even earlier, if the patient is worsening, if the patient is having eclampsia, if she's showing features of abruption, if the baby is in distress or baby has already become IUD, the only reason we are continuing is for the baby. And if the patient is showing that she is going into HELP syndrome or her platelet counts are decreasing, liver function, renal function is deteriorating, or neurological features are persisting, then definitely you have to terminate irrespective of the period of gestation. And regarding the mode of delivery, it's not mandatory that you should have a cesarean section. But many of the circumstances, once you stabilize the patient and if you feel that the patient is taking a long time to deliver, you are justified in doing a cesarean section, but only after stabilizing. And if the patient is going in for HELLP syndrome, a side-by-side management of DIC is also important. And so special points that should be considered when you are delivering is antihypertensives and magnesium sulfate should be continued. And you have to give active management of third stage of labor for these patients, but you should avoid methotrexate because she is hypertensive. Postnatal monitoring or post-cesarean monitoring is very important because many times we get patients who go into HELLP syndrome or even eclampsia in the later after delivery. Many times we get complacent after delivery and we don't monitor them much, but it is very important to monitor them for the next 72 hours. And NSAIDs has to be avoided in severe preeclampsia patients because it can further deteriorate the renal function. And if the baby has become IUD and if you want to stop lactation, do not use cabergoline for lactation suppression for these patients because it can actually have effects on adrenergic receptors and can affect the BP. And all these patients, they are considered as a high-risk patients for thromboembolism. So once that bleeding tendency is over, you have to give thromboprophylaxis to these patients, especially if they have undergone cesarean section. HELLP, I am not touching because that's a totally different part, but definitely it has to be terminated after giving steroids and, if needed, magnesium sulfate for neuroprotection. Okay. And postpartum, as I said, NSAIDs has to be cautiously used or avoided. Methyl dopa, again, we are not using it, but if it is available, it is better to avoid it in the postpartum period because the mother can have postpartum depression. Whereas the 3 drugs which is safe in the postpartum period is labetalol, calcium channel blockers, and enalapril. These are the 3 drugs which are safe to be used in the postpartum period. As I said earlier, postnatal monitoring is very important. Even if she is gestational hypertension or a mild variety, you have to monitor her closely for the first 2 days. Once you send her home, ask her to check her BP between day 3 and day 5. And then at 2 weeks and then at 6 to 8 weeks. And if the BP is persistently more than 150/100 postpartum, you have to treat them with antihypertensives. Whereas if it is a severe variety, you have to, again, very close monitoring of BP till 72 hours. And then once you send her home, ask her to check BP every alternate day for next 2 weeks because there can be complications. And definitely drugs would have to be continued in the postpartum period depending upon the BP. And if the BP is less than 130/90, you can think about reducing the dose. And all these severe patients, before you send them home, by 48 to 72 hours, please do a PIH profile before sending them home. Because we have had patients who have been completely having normal BP in the postnatal period. But when you repeat the PIH profile in the postpartum period, we have found out patients going in for HELLP syndrome in the postpartum period. So it's very important that you do a repeat PIH profile before sending them home. And proteinuria should be checked at the end of the 6 weeks. And if it is persisting, you have to think about other causes of hypertension. And all these early onset cases, before they become pregnant again, you have to evaluate them for APLA and SL. So to sum up, there are certain things which you always should keep in mind. Check BP properly at every visit. Do urine album in each trimester and each visit after 34 weeks. And always think about the trend of change in BP because many times we feel that it's 140/90. So if it is 130/80, we are okay. But suppose this patient has been having BP of 110/80 and 110/70 throughout. Suddenly, if you get a BP of 130/80, that means she is showing an upward trend. So that patient has to be very closely monitored. And also keep in mind the mean arterial pressure. So once the mean arterial pressure crosses above 80 or it reaches up to 90, you have to be very careful. And not only treating the patient is important, it is very imperative that you educate the patient about the red flags because we have had patients coming from periphery where the patient has been started on antihypertensive, but nobody told her about the impending symptoms. So the patient sat at home with headache throughout the night thinking that why to disturb the doctor at night. And then by next day morning, she went into massive intracranial hemorrhage. So it is very important to educate these patients about red flags, which you can do in your antenatal class. And if the BP is persistently 140/90, you have to treat them. And any BP 160/110 repeat after 15 minutes If persistently 160, 110, treat them with parenteral agents. And hypertension control should be done before seizure prevention. That way you can prevent an intracranial hemorrhage happen. And whenever you are referring, you should refer only after giving the loading dose of antihypertensives and magnesium sulfate. And deliver by 37 weeks in mild cases and severe cases by 34 weeks or earlier. And postnatal monitoring is as important as antenatal. Thank you. And I would like to take this opportunity to also thank the authors of the chapter in that book, that Why Mothers Die, Shekharan Sir, Chelama Madam, and Mini Madam, from where I have taken all those statistics. Thank you.
Thank you so much, Madam. I request Dr. Elizabeth, Madam, to kindly conclude the session.
I think Pramila has presented a very precise, concise, and very excellent points that need to be highlighted as far as hypertensive disorders in pregnancy are concerned. Very well done. And I think, like Pramila said, the first instituting antihypertensive at 140/90, I think KFOG has been insisting on that, though the guidelines actually do not exactly say that we need to start it early, but definitely it makes a lot of difference in the preventive aspect of patient going in for severe form of preeclampsia. The other very relevant thing I think that we need to also add up with the IHSSP in 2021 said was that regarding educating these women regarding their cardiovascular profile risk, health risk later on, in whom there is in whom they have had preeclampsia during the pregnancy. So maybe that is a window of opportunity for us as obstetricians to alert them that they should be on an annual checkup and be on a lookout for the possibility of cardiovascular health risk profile. So excellent presentation, Pramila, as always. Thank you so much. And I want to especially thank AMOG and KFOG combined effort or deliberation here today on this very relevant topics here. And thank you so much, Sneha ma'am, Neena ma'am, and all the very best wishes to both of you. Thank you.
Thank you so much, Madam. So now we'll be skipping back to our first session. I hope Neena ma'am is ready. So for the first session, as chairpersons, we have Dr. Gracie
I
Thomas.
think, Dr. Atulya, let
Yes,
me
ma'am.
check. We need to check. She is facing some problem, I suppose.
Is it? Okay.
Yeah. So I think we have to go ahead with the panel discussion.
Panel.
Yeah.
Okay, Madam. Yeah. So we'll now move on to our panel session. So our moderator will be Dr. Sneha Buyar Madam, and as experts, we have Dr. Radhamani Madam, who's a professor and past HOD of Amrita Institute of Medical Sciences, and Dr. Ambuja Mohan Madam. She's a senior consultant at GIFT IVF Hospital, Atani. And as panelist, we have Dr. Chitra R. Madam. She's a professor at Amrita. Dr. Deepti Nair Madam. She's an assistant professor, Jubilee Mission Medical College Hospital, Thrissur. Dr. Raji Raj. She's a senior consultant, Rajgiri Hospital, Alwa. Dr. Madhu Rajni, she's a consultant at Meditrina Hospital, Palakkad. Dr. Archana Dwivedi, she's a president of BOGS. And Dr. Sejal Nalik, she is a national coordinator of the endoscopy committee. And Dr. Brajbala Tiwari, she's a past president of the Indoor OBGYN Society. On to you, madam, for the panel.
Thank you so much, Dr. Atulya. Wonderful job. And without much ado, we would like to go ahead with the panel discussion. I hope you can see my presentation and it is full screen. So once again, I welcome all of you, and definitely I would take this opportunity to thank KFOG and all the esteemed faculties and the respected seniors to who are present here, especially to bless us and to guide us. So thank you so much. And without much ado, we would like to go ahead with the panel discussion. And over to you, Dr. Chitra, for this first case. Yeah. So first case, we have this primary gravida with 5 months pregnancy, and she comes with history of bleeding for vagina in the morning at home, which was painless in nature without any cause when she was resting, and it has stopped spontaneously. On further inquiry, she revealed that spotting during early pregnancy also once or twice, and she's normotensive, non-anemic, Uterus is 20 weeks size, relaxed, fetal parts well felt, fetal heart is well felt, well heard, and of course, at present there is no bleeding. So, what is your provisional diagnosis for this patient, and what further investigations you would like to go ahead as far as the management is concerned? Dr. Chitra, over to you.
Good evening, madam. Am I audible?
Yes, good evening. Please, yes.
So, being a primary gravida with a history of 2 episodes of spotting, which was self-limited, and patient is stable, fetus is correspondingly grown, and fetus parts are well palpated. I think I would like to have ask her few more details regarding the pregnancy, like whether any vaginal discharge, any sexual contact, any anticoagulation, whether she has taken, or any history of cervical procedures she has undergone, any pruritus. So these will be ruling out some of the local causes of vaginal bleeding. And on examination, we have told that she is normotensive and non-anemic, and uterus is correspondingly grown. So I would like to do a speculum examination, local examination. We should not overlook the importance of a local examination, even though we have all the investigation. So put in a speculum and see for local
Yes.
causes
Madam,
like some.
only one, yeah, I agree to all your points. Only one point I have to clarify here, whether you would like to go ahead with ultrasound first and then go ahead with the local examination, or local examination first and then the ultrasound.
Definitely, it should be a local examination. Completing a local examination, we'll be getting a paramount information, like local causes like polyp or vaginal infection may not be able to, will not be able to delineate on the ultrasonography.
Right.
So always you put in a speculum to see a local causes, varicosities, cervical erosion, polyp, etc. And once that local causes are ruled out, then we can go for investigations. Like the cornerstone of the management is always ultrasonography. So we do a ultrasonography, preferably a vaginal
Only
ultrasonography.
one doubt I have here. Suppose while doing the internal examination, you are just trying to put in the speculum and she bleeds profusely. If it is a, suppose our diagnosis, suppose if it is a low-lying placenta or placenta previa. So when you are doing the examination, internal examination, you're just trying to put in the speculum and she bleeds profusely.
Okay, so it's unlikely to bleed profusely, but because the placenta is inside
She just had the recent episode of bleeding, right? In the morning.
Self-limited, madam. So because she was not having an acute episode of heavy bleeding, so I would like to do a local examination. It may be a bleeding polyp, and if there is a heavy bleeding, we can just do a local cleaning without much pressure, and I can do a local packing also. Once the bleeding is stopped, then we can go with the either abdominal ultrasonography.
We need to mute other people. Yeah, go ahead.
So, first, and if I go with ultrasonography, I would like to get a cervical length at this point, because she already had one episode of bleeding. It could be a gradual effacing of cervix or cervical insufficiency progressing, or it might be a small the placenta located in the implanted in the lower uterine segment. Though usually we use the term placenta previa and antepartum hemorrhage after 20 weeks. Still, the migration of the placenta, which again is a misnomer, but it's the word which we usually use to explain to the patients.
If you can help us in muting others, please. Hello, Sahiti. Yeah, it is okay. So basically, she has repeated early pregnancy hemorrhage, right?
Yes.
The examination,
I would like to locate
what
the
investigations
placenta.
you want to do? Yeah.
Yeah, I would like to locate the placenta, and if there is a subchorionic collection which is draining slowly, these things I would like to do. And already fetal heart is already heard, and baby is grown correspondingly. That means any major problem should not be there. a patient is vitally stable and a self-limited bleeding.
Right. So any specific investigations you want to do apart from ultrasonography? Anything else?
Madam has already mentioned she is normotensive and anemic, this non-anemic. So
Right.
these are the common investigations which we'll be usually doing a routine panel of investigation, the antenatal, the early
Right.
pregnancy itself.
Right.
Other
Right.
than I would not like to do any other investigation.
In fact, the same thing, we want to give the message very loud and clear that unnecessary investigations we should not be doing. And of course, now we go ahead with Dr. Dipti. Do we have Dr. Dipti here in the panel?
Yes, madam. Good evening, madam.
Yeah, good evening. So, Dr. Dipti, once you have the diagnosis of low-lying placenta, would you like to go ahead with the prophylactic os tightening?
Madam, ideally, there is no evidence for cerclage in a case of a low-lying placenta.
Right.
And especially when there is active bleeding, it is better not to put a cerclage. So unless she had if she has a history indicated cerclage, then maybe previously we could do it. But otherwise, there is no evidence to.
Right. Just now, Madam Chitra talked about measurement of the cervical length, right? So when you're doing the ultrasound, of course, you're going for all the details, the features, placenta, liquor, everything, and then of course the internal os or the cervical length. So suppose if it is less than 2.5 centimeter, will you go for straightening or cervical cerclage? Less than 2.5 centimeter.
No, madam, because she may be, if she's bleeding, it is better not to do the cerclage, and it may sometimes cause more harm than.
Okay, so I would ask Dr. Chitra once again, what is your take on this? If suppose she has short cervix, as you rightly said, you have to look for it. So what is your take on this?
A gradually reducing length of cervix, that's an indication for a cerclage. But once the bleeding is stopped, and I think we can go for a cerclage in such cases.
Because already all of you are saying that it is a low-lying placenta. So if that part of the placenta is unsupported, that if that os opens, then in fact she will bleed profusely. At the same time, she will bleed before term, not even near term, right? So if you have a short cervix, that is in fact the officially or evidence-based indication for cervical cerclage, even when she doesn't have placenta previa. Agreed? Short cervix with 2.5 centimeter or less than 25 millimeter, if that is so, then yes, of course, you do have two options. One is vaginal progesterone and second is cervical cerclage, which FIGO also endorses that they are equally effective, right? So, so here, maybe we will try to go ahead with the vaginal progesterones, preferably not to go for the cervical cerclage. But once the bleeding stops, and if there is, when you go for the dynamic studies for the cervical length, if you find it is going down with 4 mm per week or so, then of course you have to go for cervical cerclage. When the cervical length goes below 2 centimeter, that is an indication. And also, as you said, the history-based, indication for cervical cerclage. What is the role of tocolysis here?
Madam, there is no role for tocolysis for the prevention of bleeding as such. But if she has contractions, we can consider tocolysis.
Right.
And
for this patient, there are no pains, there are no contractions. So definitely, it's not an indication for tocolysis. For this patient, what precautions should be advised to avoid all the complications or to avoid the bleeding episodes?
Firstly, we should tell her that since her placenta is low-lying, it may recur again. So she should be warned about it, that this may happen again and she may have to be admitted again. And so she should be she should be able to come to the hospital as soon as she has bleeding. And that it usually such bleedings, it's self-limiting, it stops on its own. And she should be advised to avoid sexual intercourse and restrict strenuous activities.
Yeah, so definitely all these precautions have to be, advised to the patient. It has to be talked to the patient in depth because already she's having placenta previa or low-lying placenta. Though not this early, we don't label it. 16 to 20 weeks, we just say it is a low-lying placenta. And then 20 weeks onwards, of course, we label it as placenta previa. So, how you can avoid all these problems when the patient starts bleeding. Definitely you have no way but just to manage conservatively and try to put this, but is there any way of predicting such kind of complications? And then of course you advise her all these instructions whatever you are giving. So what is the recommendation by RCOG?
So if the placenta is less than 2 centimeters from the os, we always call it as a low-lying placenta. And if it's near the os or covering the os, then we have to call it as a placenta previa. And we should always in our scans, we should monitor for the location of the placenta and whether there is any especially in a case of a previous cesarean or a previous scarred uterus, we must look for the retroplacental translucency, and be monitored. And we should also tell her that there is a chance of bleeding episode. There are chances that she can bleed, and that should be told to her also.
Okay.
And repeat scans must be done to see the location if it is migrating to the upper segment.
Yeah. Suppose if you have, if you find that there is no sonolucent zone retroplacenta and you feel that it is most probably a placenta accreta syndrome. So in addition to the bleeding as complication, what else you would like to counsel the patient?
Yeah,
Whether you would like to manage this patient at your individual nursing home or you would refer her to a tertiary care center?
I would definitely refer her to a tertiary care center, madam.
Yes.
And we would look out for again, how much it is invading into the myometrium. And also we would like, if necessary, we can also go for an MRI if needed. If we are doubtful, we can go for an MRI, and better to terminate her earlier at around 34 to 36 weeks.
Yeah, better to terminate. That means electively, correct? So why do you want to go for elective procedure for these patients?
Madam, because a case of placenta accreta will have unexpected torrential bleeding. So we need it to be in the daytime when everyone is available. There are anesthetists and senior obstetricians, the blood bank facilities, a urologist if necessary, and if we need a surgeon, everyone should be available, and we should plan the surgery and arrange blood and blood products prior to the take consent, inform the bystanders.
Right. So you take the consent. So how do you take the consent for these patients?
For a consent, we should always tell them that there is a chance of a massive hemorrhage. She will require multiple blood transfusions. So
it's not only for cesarean section, but it is for many other things. Yeah. So what are those?
So we'll have to tell her that she will need a hysterectomy. She may need prolonged hospital stay, ICU stay, and because of there is chance of a bladder injury. So
in spite of taking all the precautions and in spite of making all the preparedness, keeping blood and blood products, keeping the whole team, as you rightly said, senior obstetrician, senior anesthetist, NICU, neonatologist, and of course the blood bank and what you say, I think neurosurgeon, oncosurgeon, or surgeon, whosoever is available. And if at all you have the facilities for interventional radiology, those people also, right? So you can go for the uterine artery embolization. That will also further help you in reduction in the blood loss. So in spite of all these precautions, she can land up into complications. She can become moribund because of blood products and the transfusion reactions and maybe the dilution coagulopathy, maybe the trolley transfusion related complications also, and she can land up into massive hemorrhage in spite of. So you may have to go for hysterectomy and maybe even the stepwise devascularization as well. Right? So it is not only for cesarean section, but it is for a major procedure. Okay, so everything has to be discussed with the patient and with the relatives. Then only we should go ahead with the procedure. So thank you so much, Dr. Deepthi and Dr. Chitra. The case is very well discussed. So now we go to the next case. Now we have the next panelist. I think the name I think I have written wrongly, but no, we have this second gravida para 1 with 9 months amenorrhea, and she comes to you with labor pains. Pulse rate is 100, BP is good, 120, 80, no pallor, edema. Uterus is full, drum contractions 40 seconds every 3 minutes, good contractions. Contour is well maintained and head is fixed, fetal heart is also good, 140. When the patient starts wearing down and suddenly there is rupture of membranes with fresh gush of bleeding, and there is a sudden drop in fetal heart. Okay, so what is your diagnosis and how will you manage this patient? Can
Can
we?
I take, ma'am?
Yes, please.
Yeah. Ma'am, I think it can be if she's having very strong uterine contractions and probably she may have the abruptio placenta and there is a gush of blood and along with that the drop in fetal heart rate. So I guess we'll have to look out for the abruption or maybe the precipitate labor, maybe the cervical tear because she started bearing down. So
okay.
These are my probable.
Yeah. So any other differential diagnosis from the panelist?
Can it be vasa previa?
Yes. So how do you explain that? Can I
She
say? Yeah, please.
she had a spontaneous rupture of membrane and with a bearing down and an immediate sudden drop of fetal heart rate. It's a rare cause. We cannot, usually the first told diagnosis will be the most probable ones. But
Yes.
the rare one
But
can
can
be
you see the findings? What we are saying, she's absolutely normotensive, right? That is one. Secondly, the uterine contractions are very optimum.
Optimum only. She is not having any hypertonic contractions. Uterus is relaxing in
Contour
between.
is well maintained. Fetal heart is good initially. Just by bearing down, whatever complications that is happening here because of rupture of membranes and then the fresh gush of bleeding. So here the diagnosis is otherwise very clear cut if we discuss so, right?
Mm-hmm.
Yeah. Can we see who is speaking? This is
I am Dr. Rajesh. Sorry.
Right, Rajesh. Right. So correct. So actually, this is the clinical scenario where it is the diagnosis very obvious. But as Dr. Sejal said, that also could be possible. Maybe if it is a fresh separation of placenta, right? If it is not a concealed one, then of course maybe it is just a fresh age separation and she is bleeding fresh. That is one possibility. But the more accepted diagnosis for this case is of course the vasa previa. That is very, very classical. That thinks everything is normal just after the rupture of membranes. Very classical because the vessels run across the membranes, no, amniotic fluid membranes, and then amniotic membranes, and then when they give away, the vessels get torn, and that is why there is bleeding. And this bleeding, though it looks very minimal bleeding, it is a fetal blood. And that is why the fetus, lands up into distress. So how would you manage this patient, Dr. Raji?
If she is already fully dilated and if an instrumental delivery can be accomplished at that point, I will go for an instrumental delivery either with a vacuum or a forceps. But if it is not deliverable vaginally, I will go for a crash cesarean at this point.
Yeah, but then would you like to give this some message for this vasa previa, because this is a very notorious situation, I would say.
Usually it can be associated with a velamentous insertion of cord, and sometimes ultrasound you can see the leash of blood vessels running across the internal os in the lower segment.
Right. Even the moment you feel or you suspect that it is a rupture of vessels from the vasa previa, you have to rush for help and make all the arrangement possible, because the modality, whatever modality is possible, you can deliver the baby at the earliest that should be chosen. May it be vaginal instrumental delivery or a cesarean section, right? Because in spite of trying everything, this has been associated with almost 60% of fetal perinatal mortality, right? So that is why having the high index of suspicion, early recognition, and going ahead with the definitive management at the earliest should be the way to manage these patients. So can it be diagnosed on ultrasound? I mean, we always introspect ourselves that if at all this catastrophe has happened, could we prevent this? So was this a preventable situation in this era of color Doppler, power Doppler? Yes, Dr. Raji?
Yes, definitely yes.
Yeah. So as you rightly said that whenever, especially when you have low-lying placenta, then that is getting migrated. That is one situation. And of course, the velamentous insertion, maybe sometimes the suction surate lobe of placenta, if you have the vessels running across the internal os, that is a situation. So these can be diagnosed on ultrasound. The color Doppler can definitely pick up these things. And that is why if you diagnose such cases, then I mean, not to allow these patients to go into labor and go for the elective cesarean section. That is the best way possible, I would say. Right. So this is what was the case. And you can see here the velamentous insertion or the battledore insertion. These are the common cord insertions. And in the other picture, you can see the torn fetal vessels here. Right.
Madam, can I make a point
So
over here?
yeah, please.
Yeah, ma'am, a very nice presentation. I think this is something which you have brought out very nicely because it's often near miss cases, because sometimes in periphery we have seen that patients have been done unnecessary per vaginal examination and torrential bleed and they land up. So diagnosis, as you said, I'm thankful that you brought up this case. The diagnosis is very, very important. Thank you, ma'am.
Right. Thank you so much, Dr. Archana. So we go ahead with the next case now. We have, I think this is for Dr. Raji again, but if we have somebody, can we know who else is, apart from our experts, Madam Ambujan and Madam Radhamani, who are the panelists? Can we know? I can see only 2-3 of them. Dr. Brajbala is there, and Dr. Dipti we have just had. And of course, Dr. Madhu. Do we have Dr. Madhu? Do we have Dr. Madhu?
Yes,
No.
ma'am. Yeah,
Yes,
ma'am.
Yeah,
yes.
even this third question.
Yeah. Thank you so much. Yeah. So we come to you for this case. We have this 32-year-old para 1 woman who has had previous 1 seizure and the male child 1.5 year. Madam Mujam, please
Yes,
let me know if at all you want to make a comment, anything on these 2 cases, please let me know. Otherwise, I will invite you for this case.
Early pregnancy, spotting present.
This case. I will invite you for the comments for this case, madam. So we have this para 1 previous 1 seizure section, and of course a child only 1.5 years, and she comes to you during 6 months because she's transferred because of the husband's job transfer here, and she comes to you with history of spotting, and you do her ultrasound, so you find that the placenta is low lying. And of course, there is a absent RP lake and lots of vascularity on the lower segment. Anomaly scan is normal. Now, on further inquiry, she gives you a history of spotting during early pregnancy, and even the earlier ultrasound report has revealed low-lying placenta. Right? So this is the case. So all of a sudden, at 30 weeks, she started bleeding profusely, significantly, and she's collapsed in front of you. So what is your diagnosis and how will you manage this patient? Dr. Madhu.
This is a 32-year-old lady with the previous cesarean section, madam. And low-lying placenta already diagnosed, and she came with the torrential bleeding and collapse. Actually, with the ultrasound in any pregnancy with previous section and a low-lying placenta, we have to rule out the placenta accreta also. Okay.
Right.
In this case, we have to do the vitals first and resuscitate and call for help, IV cannula and arrange blood and all that. And we have to see how is the fetal heart. And 30 weeks, and if she is torrentially bleeding, with the baby is okay, and if bleeding is controllable, we can go for observation. Otherwise, if first the maternal morbidity, we have to a priority.
Yeah.
Priority must be the maternal morbidity. Then only we have to
Right.
look for the fetal heart. First, we have to
Right.
start the IV fluids and the blood also to be arranged. And when the ABC, resuscitation and everything, if the mother is okay and the bleeding has stopped, we can go for the diagnosis of the fetal heart. How is the baby? And if the baby is okay and the fetal, this one, bleeding has stopped, we can continue. Otherwise, continue with the pregnancy. We can give steroid also. If there is no pain, we can wait. 2 doses of steroid we can give. Otherwise, if the bleeding continues, we have to do an emergency cesarean section because it is a previous cesarean section, and we have to do, we have to suspect placenta accreta or percreta and all that. We have to have a multidisciplinary team with us.
Right. So, Dr. Madhu, Madam has very nicely, in fact, I wanted expert comments from Madam, but Madam has primarily given us the entire discussion about the case. So, I would just ask you, we have already discussed one such case of placenta previa. So, for this patient, at 30 weeks, when she has collapsed and you are managing her, what would you talk to the relatives about the baby?
In this patient, our primary concern is about the maternal stability. So first, our priority is about the mother. So the baby comes only next because it's only 30 weeks and there is high risk of prematurity. And already since she is bleeding, the viability of the baby and that all comes into query because it definitely need an expert NICU care. So the primary, our goal is to save the mother. So when we discuss with the bystander,
Sneha,
yes,
the patient's relatives, we'll have to primarily focus on the mother. And
hello, Madam Radhamani wants to add something.
Yeah, actually, at any gestation, the bleeding is torrential and affect the hemodynamic instability. We need not depend on the gestation at all and need not. So that is it. Second bout of bleeding usually will not be heavy. Another thing is placenta again, which may not have that much of bleeding will not occur. Other cases, 30% of the cases may bleed before 30 weeks. That case is actually end in preterm labor and also blood transfusion may be needed. So whenever usually the second bleeding also may not be heavy, but third bleeding onwards, if the patient is having bleeding, you need to admit the patient to see that whether the bleeding recurs. If the bleeding recurs, irrespective of gestation age, the mother is hemodynamically unstable, we have to go for a cesarean section with arranging everything with massive transfusion protocol.
Right. Exactly, madam. So when that is the reason we wanted to discuss that when the patient has collapsed in front of you, we have to think for the mother, and definitely we should arrange everything for operative intervention and blood production. Go ahead with the operative intervention, which should, make the patient safe. So we very well agree with you. And as madam has said, okay, maybe the 30 weeks gestational age baby, if at all you have the facilities, you can hand over the baby, and of course you try your best, but your first and foremost aim should be to revive the mother, to stabilize her, and go ahead with the operative intervention, the definitive intervention at the earliest. Any difference of opinion here once again? Madam Radhamani and Madam Ambujam. Madam Ambujam, do you want to add anything?
No. In all cases of placenta previa, we have to suspect placenta accreta also, especially if the patient is having first trimester bleeding and ultrasound is having an hematoma behind the placenta. We have to anticipate risk of abruption also.
Right.
And in all cases of antepartum and intrapartum hemorrhage, especially if there is a scar, we have to suspect the uterine rupture also. Must be, and uterine scar dehiscence or rupture must be excluded.
Right. So the other discussion for this case, having a complete team of multidisciplinary team and the blood products, everything has been discussed. I would just ask only few questions for this patient, Dr. Brajbala. We have decided the team, yes, we have to go for emergency operative intervention. So you have already taken consent for the emergency obstetric hysterectomy also, cesarean hysterectomy, right? But
Yes.
then when you are opening the patient brush, what will be the abdominal incision and what will be the uterine incision?
So basically, this type of patient should have been labeled from the beginning very, very high risk patient, because she was previous section 1 year back only and there was low-lying placenta. So beforehand, she should have been conceived. Once she came with and collabs with us, we need a multidisciplinary approach, expert surgeon with us, expert anesthetist on the blood products and vertical incision. And in uterine incision above the placental margin, and not to injure the placenta, and whiteboard this intracate blood products, and we have to keep the patient in ICU, that we have to consult beforehand.
Right.
So
So
the incision is ideal because just saying if it not definitely need a hysterectomy, because we can go for compression sutures and devascularization. Even sometimes we can control the bleeding by Indian cardiac ligation. So always go for a vertical incision instead of thinking of uterine embolization. Already the abdomen is open. So you are always vertical incision on the possibility of either applying aortic clamp or Indian cardiac ligation. Always a vertical incision. Number 2, because there is a bleeding, and then maybe the patient can go for a hyperfibrinogenemia and EPH and even a DIC. So vertical incision is ideal because the hematoma formation is less. I always have to anticipate these type of cases wherein we have to go for a vertical incision rather than a fancy incision, because chance of hematoma is high. In this case, there is a chance of DIC.
Right. Very well said, madam. And in fact, though we take the consent for the cesarean hysterectomy, we have to, when the patient is stable, this is the time where you can go ahead with the conservative uterine conservative surgery. As you rightly said, that you have the procedure what is called as triple P procedure. So can somebody talk about the triple P procedure? Dr. Archana, whom I can say, Dr. Madhu. Do we have Dr. Madhu? And come back to, yes, Dr. Madhu. Okay, Dr. Raji.
Actually,
please.
In the center which I am working, actually, Dr. Piley is also working here. But usually in these cases, we go ahead with the obstetric hysterectomy after applying aortic clamp. Triple P, as you have already told, is a conservative approach in which the 3 P stand for perioperative. Will localize the placenta where the placenta is extending. We'll plan our incision accordingly. And the second P stands for the stepwise devascularization. We'll put an incision, deliver the baby. We first of all will input the incision just above the placenta without cutting through the placenta, just above the placenta. And we after delivery of the baby, we go for stepwise devascularization, and then we will be excising that segment of myometrium, in which without separating the placenta, that is the third P. Without separation of the placenta, we will go ahead with the removing that myometrium in which the placenta was adherent, and then reconstruction of the uterus.
So that is
actually
myometrial resection, we call it as, Yeah. So what are other methods of other uterine conservative surgeries, if at all anybody knows about it?
Yeah, we can go for actually compression sutures. See, especially in posterior placenta, we could see that even if you put sutures inside the uterine cavity to control the venous bleeding from the venous sinuses, or even you are putting
the placenta in situ,
even you are putting ligatures around the internal loss also, the bleeding can persist. Always deliver the uterus and see the posterior segment, posterior aspect of the uterus, especially placenta is posterior. Thin the myometrium we can see. You put a compression suture all area there, definitely the bleeding will be controlled.
But with the placenta in situ, we have to remove the placenta, right?
Yeah, after removing the placenta, after removing the placenta only, if you want to conserve the uterus. If it is posterior placenta, even after putting either uterine artery ligation, it will bleed because it is atonic at that area. So you have to compress in your hand actually with your fingers and thumb. You can hold that part and then put compression sutures with your hand and then put the compression sutures around it.
Yes.
It definitely it will control. I've had several instances where I could conserve the uterus.
Yeah. So there is these two methods, and there is one more method, what is called as Comoc MG stitch. So recently, Dr. Mahesh Gupta, he's been doing lots of such cases, and in fact, he's demonstrating on a majority of our programs. He's joining also. So what he does is he occludes the upper uterine artery first, and then he takes a cervicoischemic stitch on both the sides. So upper and lower uterine arteries he occludes, and then the field becomes absolutely avascular, and then it tries, just scratches out the placenta, and then he takes a compression sutures, or maybe the whatever sutures required, though not exactly the compression sutures. And then, in fact, whatever cases he has shown us till now, the uterus doesn't bleed after he goes for these upper and lower uterine artery occlusions, in addition to the state-wise devascularization. Of course, he starts from internal iliac and then goes ahead with this. So the uterus becomes so avascular that when you scratch out this placenta, it doesn't bleed much, and then he sutures the lower edges of the cesarean section also very well. So there is absolutely no problem. That is what hundreds of cases are coming up. So maybe we have in few coming months or years, maybe we have a good data, and of course all of us build courage to do such things also. That is what we feel. So we have actually witnessed such cases, so we are quite sure that yes, definitely it's going to help in future. So this is also one more, but then of course, till the time we do not have definite procedure or that expertise what other people are having, maybe for us theoretically or maybe practically also, the emergency obstetric hysterectomy is the definitive treatment for such patient. So what precautions you have to take, we have already said, but I have also mentioned here spatial aorta clamp, that is Dr. Piley's clamp to be applied at the aortic bifurcation, and that sir has actually come on one of my programs, and he only has demonstrated this, so we know definitely helpful for this. Nowadays, people are coming up with aortic balloon, that is as an interventional radiology procedure. So that is also quite helpful in reducing the blood loss at operative procedure. Definitely extent of the placenta, the depth of the placenta, placental, what you say, the attachment, you can definitely trace, and of course, depending on that, you can decide whether you can go for a conservative surgery or not if the patient is stable. So that is what about the placenta accreta syndrome. And then we go ahead with the third case now. Dr. Archana, this is a case for you. We have this 20-year-old primary gravida, 9 months amenorrhea, referred to the hospital at around 11 p.m. This lady was in labor pains since maybe from 3 p.m., that is around 8 hours, in a nearby small nursing home. So there's a failure to progress. So they decide to take her for cesarean section. The sister catheterizes the bladder. There is no urine output. So on further inquiry, they find that over last maybe 8 to 10 hours, she has not passed urine. So she was referred to this tertiary care center. So here, pulse rate was 110, BP was 110/70, uterine contraction very, very strong, severe in intensity. Fetal heart is only 120, and the dilatation is not 7 centimeters, sorry, it is 2 centimeter only. So can somebody mute this? So membranes are absent and there is fresh brownish color or altered blood. Okay, so what is your diagnosis, Dr. Archana? On priority, what is your diagnosis, primary diagnosis?
Madam, this is a young girl, 20 years old, full term, as she has come for the normal labor with
only diagnosis. Only diagnosis.
This is abruption. This is concealed hemorrhage and abruptio placenta likely, and along with DIC and acute kidney injury.
Because now these investigations are provided to you. She's got hemoglobin 8% platelet 1 lakh only. PTINR 2 and APTT prolonged. FDP is present and fibrinogen 150 mg%. Now what is your diagnosis? And how do you tackle? What are all the problems you have to tackle?
So there are 3 points here, madam. First of all, she is clear-cut case of abruptio, concealed hemorrhage. And then we also have a case where there is an acute kidney injury. And along with that, prolonged labor, maybe multiple pervaginal examination. So we need to take care of the DIC also, because all the parameters seems to be disturbed over here. So this is the patient shifted to the tertiary care center immediately. No hurries to put the Lasix. Most of us do that wrong thing, that putting up Lasix. Rather than shout for help, arrange blood products simultaneously, monitor us by ultrasound whether fetus is alive, because fetus bradycardia is also there. Once the fetus is dead, our management will be focused on the female only to resuscitate her, and then go for a normal delivery or a cesarean section depending on that. But if the fetus is alive, arrangement of the products, good ICU center, NICU, pediatrician, senior gynecologist, team which is already trained, because she will require wide bore cannula insertion, arrangement of blood products, giving cryoprecipitate, PCV 4:4:10 ratio, I would say. PCV 4 FFP, and maybe 8 to 10 cryoprecipitate, where we don't need the blood grouping immediately. So this will be the primary arrangement. Till then, you have to give the...
Excuse me.
So restore her volume basically, because fetus is irritable, she'll go on bleeding, and a high upgradation of the antibiotic. I will go for tazobactam piperacillin in this
so
case,
now
and
that
also involve the nephrologist,
Dr.
madam,
Archana,
because she...
let me stop you here. You have discussed, because you find that this patient is in hypovolemia, you're trying to aggressively resuscitate her.
Yes.
But then my question is, this dilatation is not 7 centimeter, it is 2 centimeter. My question to you is whether the patient has got fetal distress, so whether you want to go for cesarean section first or wait for the blood and blood product. Very clear question.
Madam, if I am working at a tertiary, can say everything is in hand for me. But if you are into a center where you need to arrange things, then no hurries about the baby part.
Will take some time, right?
Yes. So cesarean section would land into mortality and morbidity. So no hurries. First, we have to manage the product, because now here the mother will become more important. The time lapse which is required is required. So till then, you have to resuscitate, oxygenate the patient, give a left lateral position, and involve your team for her monitoring. Aggressive monitoring is required in this patient. ABG scores should also be done, so that she's not goes into the hyperacidosis. Even electrolyte balance we have to manage. Simultaneously providing, preventing ARDS, because hyperperfusion may also land up into complications. So if I have to decide for the mother, I have to decide for the mother prevention first rather than the baby. But if I have got all the things arranged in hand, I would like to preserve the baby as well. I mean, give her a better outcome in terms of baby, because NICU care may help resuscitation of the baby as well.
Yes,
but
because
priority will be
baby is term baby. Okay. So, Madam, yes. Any comments from?
Put any bleeding, only fetal heart 120 per minute, and
She
hemoglobin.
has altered bleeding. She has bleeding. She has altered, madam, I'm talking to madam. She has altered bleeding, that is because of the concealed hemorrhage, right?
Concealed hemorrhage.
Yeah, consumption coagulopathy, madam. Basically, consumption coagulopathy along with component of sepsis also we have to consider. So dilatation is not there.
No, it's not a question of sepsis. Here, there is no question of sepsis. It's a question of 8 to 10 hours only. And this patient definitely has abruptio placentae, and she has landed up into DIC.
Yes.
But she has landed up into acute renal failure, that is acute tubular necrosis.
That is very important.
Hypovolemia. That is because of the hypovolemia. Okay. She has got massive concealed hemorrhage. That is why the fetal distress, grade 2 to grade 3 abruptio almost she has. So first and foremost, you have to correct her hypovolemia. Once you correct her hypovolemia, the renal perfusion will improve, and of course, your patient will not go into irreversible renal failure, that is acute cortical necrosis. Okay. So anything.
So good ultrasound cannot be ruled out, madam. A good ultrasound should be done.
Archana, wait. Madam wants to add something.
Okay.
Madam wants to add something.
See, as it is, she's near to full dilatation, isn't it?
No, madam. That is actually wrongly printed. It is 2 centimeter only.
Okay.
She's not progressive.
So
not progressive.
actually, ideally, when fetal heart is present, we have to go for section. Simultaneously give the blood and blood products immediately. If it is a tertiary concern, that is possible also. You can also use TEG or ROTEM in the theatre if it is provided in the theatre. And actually,
that is what is the answer expected. That is what is the answer expected, madam. You have banged on it. Simultaneously, everything. Arrange for the operative procedure, arrange for the blood and blood components, and by the time it gets available, you resuscitate the patient with the volume, and then of course by the time the blood components are available, start with the operative procedure, because here this patient doesn't have much of a coagulopathy. It is just the beginning. In fact, it is the abrupt delivery interval also that is very, very important, and that will worsen the situation if you keep this separated placenta inside. Okay, so here the FDP is present, that is the indicative of, but the platelet count is near normal. The fibrinogen is 150. So you can still go ahead with the operative procedure when you are trying to arrange for all the blood and blood components. So definitely everything has to be simultaneously, which will optimize our treatment for the mother and for the baby as well. So restoration of volume, you have said it, hematocrit, coagulation factor, electrolytes, everything. Avoid overload and maintaining all the organ functions. Eliminate the underlying cause, that is the abruptio placentae, right? And expedition of delivery with maintenance of hemostasis. Of course, this patient who has landed up into EPH because of all these problems, she is very prone for to go into PPH, and that is why we have to take care of this patient, prophylactic oxytocics also. And then of course, all of you have said it, what is the targets of therapy and how do you go ahead with the management. Now, I think we go
one point I want to...
Yes, please.
I can make a one point. See, ma'am, AKI cannot be just taken like we should manage. In the medico-legal era, we should involve a nephrologist always, because sometimes in my practice, I have dealt with 4 or 5 cases where the patient required dialysis for the temporary time being. So it is always good to involve people so that it's a help to you also. And some people may require dialysis 3 or 4 times to regain the kidney function. Immediately,
yeah, see, if it is a acute tubular necrosis of such short duration, that doesn't require anything. Just regaining the volume, giving Lasix, or it is called as the test of IV fluids or even the forced diuresis. If that can solve your problem and your renal functions parameters are coming normal, there's no need. But if this insult is there for a longer period, which we are trying to tell you that we should not allow our patient to go for the irreversible damage, right? And that is why we need to act fast. So thank you, Dr. Archana, for your inputs. We have Dr. Sejal Naik from Surat. Dr. Sejal?
She's there.
Yes, ma'am.
Yeah, so you have this second gravida para-1 with previous Caesar, 36 weeks pregnancy, and she's got dyspnea since 8 to 10 hours. She comes from a neighboring district. She's got gestational hypertension. Okay, her echo. This is a case from Tamil Nadu, so they always go for echo for the pregnant ladies. So echo is suggestive of mild tricuspid regurg. This patient is semi-conscious. Pulse rate is 120. BP is 100/70, her SaO2 is below 90. Uterus is full term, relaxed, fetal heart is good. Everything at this point of time, the pregnancy parameters are, good. Ultrasound is done previously. It is not showing any abnormality. So only thing is she was semi-conscious and dyspneic. Okay. So I think this patient worsened, and at around 6 a.m., she needed to be incubated and shifted to ICU. So here she started having epistaxis, bleeding per vaginal also, and the fetal heart was absent. Investigations were suggestive of the coagulopathy. Okay, the ultrasound is ultrasound done that time. It was suggestive of ruptured uterus and fetal demise. So how do you correlate all this sequence of events, and how do you tackle the coagulation failure?
Yeah, ma'am. She came already with the low SpO2, so then she collapsed.
Yeah.
So we should rule out like cardiac issues.
Yes,
And cardiologist should be involved here.
Right.
And
And
unfortunately,
cardiac and respiratory, because these are the primary.
yes, of course. Yes. So she has a dyspnea along with this. So maybe the pulmonary hypertension or the cardiac failure is there, and that hypoxic state should be corrected. She underwent she went like she is already intubated, right? Because she collapsed there.
That she worsened. That is why she needed
Worsened,
to.
yeah. After admission, she worsened.
Yeah.
See, madam, here the primary that would be the maternal that this is the time where we have to balance between the like whether to go for the laparotomy or whether we have to the same question whether we have to wait till the coagulation profile comes normal. So these both goes hand by hand, ma'am. We have to manage with the platelet concentrate and the other fibrinogen factors, fresh plasma.
Why do you want to give platelet concentrate to this lady?
So she's having epistaxis and bleeding also.
Yeah.
And we'll have to investigate further her
in other
coagulation profile.
When do you need the platelet transfusion? Even for operative procedure, how much?
If it is less than like 50,000, and then we have to replenish the platelets. We have to create the window of safety where we can operate her safely. So simultaneously with transfusion of these products, along with that the laparotomy, because she is already having the rupture uterus and she is bleeding inside.
Yeah. Okay. So Dr. Sejal, my question is not this management, because now the management is very obvious, but already when the fetus is dead, she already has rupture uterus. Now the things are gone beyond your control. This is only what you can say. It is only, this is not the definitive management per se. What we want to know from you is, what is the diagnosis of this patient and whether this could have been prevented?
Let me say one thing, Sneha.
Yes, madam, please.
Yeah. See, one thing is not mentioned about the hemoglobin. Number two, why can't we go for an ultrasound at the time when the patient is
exactly, madam,
8 to 10 hours? We have lost that overnight and then allow the patient to die in front of us. So it's a great mistake. Actually, we could have done. I have one of my opinion is, why can't we go for a section at that time? Patient is intubated.
Exactly. 36 weeks pregnancy, that too, not even 32 or so, 36 weeks pregnancy, previous one Caesar. As it is, she was going to land up into Caesar only. Why not to consider this way? Previous one Caesar, 36. This patient who is, semi-conscious, arterial saturation, 90% only. Why don't we, have a high index of suspicion? Why did the alarm ring at this point of time to involve the other fellows also, no? Cardiologists, physician, intensivist, why it was not involved? Because I don't think if at all we get such patients, will we admit her and keep her till morning, Sejal?
No, ma'am. We such a patient are into the intensive care unit only. From the very beginning. From the very beginning.
Yes.
And the multidisciplinary modalities to be taken.
That is what. In fact, this case is only to introspect that, we say obstetrics is unpredictable. How much it should predict you? See, she's got SAO2 90%, even the BP is on the lower side, semi-conscious, there's tachycardia, tricuspid rigid, everything is there. Previous either 36 weeks, so many problems. And this patient should...
And one more thing, madam, there is a known case of gestational hypertension and presented with us with 100 by 70 BP. So that is one of the very important signs that should not miss.
Right. So all this theoretical aspect, this scoring the DIC, whether it was over DIC or it was a occult DIC, whatever, this comes later, and this has no significance. Theoretical knowledge is... We have to know what, we have to have a high index of suspicion. Clinical acumen should be so good that we should feel that no, this patient needs something else, not only the obstetrician and the routine hospitalization and management, right? So for this patient, restoration of normal blood volume, coagulation status, that is the main part of the management. Then she received 4 units of packed RBC massive transfusion protocol was initiated. All these things, crystalloids were started initially, and then she underwent that bedside test, and then of course this, I would say, this fibrinogen levels, no, actually normally you need 450 milligram it should be, but it was only 150 here, and definitely she's into she's gone into degradation products also, fibrinogen. So these are just the theoretical aspect, but what to introspect for this patient? Cesarean section now actually it was indicated much when she came to you. But now that everything is over, almost, you have pushed this patient into this catastrophe, and now we have to go for cesarean section. So that is the irony of the situation. Anesthetist team was informed, central line was put, massive transfusion protocol activated, and then she was taken up for laparotomy, rupture uterus with placenta accreta. Okay. So this previous Caesar, placenta accreta increta. Okay. So this patient was she must have started having that process of separation that time only when she got admitted in the evening, when she was having slowly fall in blood pressure, and even the dyspnea she was having because of all these things, and that was missed. So this patient was also the patient was lost in OT. This is a case which I told you, I've written in the beginning, that this patient was possibly admitted with ARDS as a complication of hypertension. She landed up into DIC and then the morbidly adherent placenta, leading to rupture, that adding to the problems, and then everything, delay at every step of diagnosis and management has led to the death of this patient. So this is what I just brought in this case, how one can mismanage such a very, very clear-cut patient. And that is why I always give the message that we have to keep a very high index of suspicion. Previous Caesar, the bell must ring in, that you should always think of all these things and don't take her as a routine obstetric patient or routine labor, woman in labor. That is how the message is. Should we go ahead with the next case? Dr. Dipti? Should we have this as a last case? Dr. Dipti Nair, do we have Dr. Dipti here?
Yes, madam.
Yeah. So, so sorry, you are silent from since long time. We now will ask you the entire case, we leave it to you. So we have this 25-year-old gravida 2 para-1 with 33 weeks, otherwise uneventful pregnancy with history of abdominal surgery previously. She comes with severe pain in abdomen. She could not even stand upright. Okay. It was not a case of previous seizure. It was a case of previous some abdominal surgery. Okay. Pulse rate 120, BP 90/60, uterine height corresponding, fetal height is 120, but uterus is tender, cervix closed on PV examination, no bleeding or abnormal discharge. What is the diagnosis for this patient, and how will you manage?
Yes, madam. Madam, it says no history of previous abdominal surgery. So she was, she had no surgeries before. And here we have a tender uterus, and it could be a concealed abruption itself because of the severe pain and tender uterus, but and she has no bleeding. So it's probably a concealed abruption. So in this particular case, I would like to, as discussed earlier, firstly, we would go into volume replacement. We'll start we put IV cannulas. We'll start in, we'll have to send investigations. We'll have to see if she is in coagulation failure. We'll have to check her HB, platelets, BT, PT, APTT, INR, fibrinogen levels. And also the renal function, liver function test should be done. And then we would go into, we'll have to decide on terminating the pregnancy in case it's an abruption. We can also go for an ultrasound. But before that, we'll have...
Dr. Dipti, I would just interrupt you here for a moment. she's normotensive, otherwise uneventful pregnancy. Okay. What do you think the cause of abruptio? You're right that she's got concealed abruptio. I fully agree with you. What can be the cause for abruption?
It could be a trauma, madam, or it can be
We have to ask the history.
history.
Ultrasound, madam. Ultrasound. Ultrasound. It may be simple.
History doesn't tell you, then of course investigate. So ultrasound. Ultrasound will tell you what?
Retroplacental clot and the jelly sign because the placenta may be thickened.
Yes.
Ultrasound
not reliable in all cases. If it is there, it is obviously an abruption.
The placenta clot may not see, but you can see the thickened placenta. That itself shows that there is abruption actually. Especially when there is a placenta is located in the posterior, we may miss. Definitely patient may not have any tenderness or pain.
Okay. So we divert our attention or maybe we broaden our view. Let's not focus only on the placenta. It's a concealed hemorrhage. I fully agree with you. So apart from separation of the placenta and RP clot, do you see anything else which can guide you? Yes. So this ultrasound showed a live fetus, transverse live, appropriate growth parameters, amniotic fluid, everything. There is a huge subchorionic hypoechoic area and the placental tissue is thicker than normal, as madam said. Okay. So fetality is only 90. Now here the uterine arteries could not be visualized even with color Doppler. What's the significance for this?
Could it be a fibroid uterus obscuring and the placenta is attached over that? That might be triggering the abruption.
Okay, something, anything else?
The angioma or chorioangioma,
This
something like that.
arteries, no, with uterine arteries, they could not be visualized. You know, either they are compressed very tightly.
Yeah, because of huge subchorial hemorrhage, you may not be able to see the uterine arteries.
Okay. Okay, so let us come to see what this patient had. Actually, emergency cesarean section was performed. This is a real case from which happened in Nagpur, a city closer to my neighboring city. So, emergency cesarean section was performed under general anesthesia. Approximately 100 ml blood, that too in the peritoneal cavity, and then of course a huge retroplacental clot. Amniotic fluid was surprisingly clear. Male fetus transverse live delivered by podalic extraction. Baby was live but pale, hypotonic. Large quantity of fresh blood came out and placenta had large RP clots. Uterus was ischemic, totally floppy. Exteriorization was done and uterus was rotated to 180 degrees. Okay. So detorsion was done for this uterus. Okay. And in a matter of few seconds, myometrial tone regained and there was superficial laceration on the posterior aspect that was taken care of. There were no myomas and no uterine malformation. Okay, so this was a case of acute uterine torsion. And yes, when I had discussed this case in previously at least 1 or 2 sessions, there were few seniors who had actually shared their experience of facing similar situations, like the uterine torsion. The very fact that she tells you, she's not even able to stand erect. The complete rotation or the torsion of the uterus, there's so much of stretch on the sacral ligaments, and that was very, very suggestive of, and that is how the patient presents. That is what is the experience shared by some of the seniors who have faced and managed such cases. So naturally, all the rest of the management, all of you know so well. So I'm going to skip this. Of course, once again, I have the blessings from the yes, and I thank the experts, Madam Ambujam and Madam Radhamani. Of course, I will invite you, Madam, to make few comments. But before that, yes.
Any patient coming with acute abdominal pain in pregnancy, we have to have ask the history of trauma. Nowadays, violence against women is common from husband and all that.
Yes,
trauma So we have to ask the history is important.
Yeah.
Thank
So,
you, Sneha, and the panelists for a
yes, madam, wait for a moment. I'm going to invite you for special comments. So I just seek your blessings, and of course, all of your blessings and good wishes. Loads of everybody for my candidature as Vice President from West Zone. So the elections are coming very, very close, and that's a very reason I request you from the bottom of my heart. I thank all of you. And before I close this session, I request Madam Radhamani and Madam Ambujam to make few comments regarding the session. Your expert comments, Madam.
Thank you, Sneha, for the thanks for the panelists also. I would like to stress only one point. My video is not working. That's why moments are not seeing. Actually, I would like to say about the first case. Actually, prophylactic circular is needed in this case. Only thing is you can go for McDonald instead of a Shirothar because bladder dissection is not needed, number one. Number two is when the placenta is relocated after 26 weeks, definitely we have to go for a Doppler to rule out a vasa previa. That because that awareness patient we have to give, and then we must also know that there is a chance of vasa previa in this case. Because the relocation plus that 26 weeks. So tell the patient about the how much about the scan and about the restrictions already deeply told. And about again, this is about the other cases. And another most important thing is also we have to get awareness about the patient because it's a high risk case going for abruption later or fetal growth restriction. That also is a complication we need to anticipate in this type of cases. All other cases actually we have decided, I think so.
Right. Thank you so much, madam, because of your experience, definitely I did say that whenever you feel the report says there is a migration of the placenta which was initially low lying, that is a case where you have to keep the high index of suspicion for especially this vasa previa and even sometimes the cord presentation that also can happen. So definitely, madam, your comments are very precious. May I request Madam Ambujam also to make few comments?
In cases of unexplained antepartum bleeding, neonatal complications and growth restrictions are more, so that we must be very careful and we have to prepare for that. And in recurrent antepartum hemorrhage, we have, if the patient is Rh negative and if it is CLIHAR is negative, we have to give her anti-D prophylactically every 4 to 6 weeks injections until delivery. And the massive APH, in massive APH and intrapartum hemorrhage, we have to give the prophylaxis, thromboprophylaxis in all cases.
Right. So thank you so much, madam. I think I would just say that, madam, though it has been already introduced me as having so many international and national awards, I would say I'm a very hard-working, passionate obstetrician, practicing obstetrician, and with 35 years of experience now. And I'm a very humble human being, one amongst you. So request to please support and vote for me. And of course, we have some of our friends also who are also contesting. So they also need your blessings and best wishes.
Thank you, Sneha ma'am. We will definitely support you. Thank you for all your nice comments and nice information. Thank you very much.
Thank you, madam. Thank you so much.
Dr. Sneha, may I request for Environmental Health Committee Chairperson election? So please do support me for this upcoming election. I am working for environment since last 2 decades, so I need your support. Thank you so much.
Thank you. Definitely, ma'am.
Thank you, Brijmala, and thank you, Ambuja ma'am, for your inputs. I mean, the experience which you carry with you and Sneha ma'am's inputs. I mean, the practical cases. Thank you for making me a part of this beautiful panel, ma'am. And requesting your vote and support for Midlife Management Committee this year, ma'am. I'm contesting for that. My passion is menopause, and I have been working in Indian Menopause Society for the last 15 years. And also a website committee chairperson at present, and have won many awards in this field.
And today I'm very proud to share that one of my articles that menopause hormone therapy is the gold standard therapy was released on 6th of July for the Mint Journal of Hindustan Times. So that was a proud privilege to share this platform right now. Thank you, Sneha ma'am, and team for giving me the opportunity, and seniors for their blessings. Thank you so much. And once again, a request for Sneha ma'am. She has been a very hardworking person. I mean, no other choice from our side, and we request to support her in her endeavor also, ma'am. Thank you so much.
Thank you, Archana ma'am. We see you on Sunday.
Yeah, sure, ma'am. In the morning. Yes.
Yeah. Thank you.
You're always there. Thank you, ma'am. Thank you.
Thank you so
Thank you, madam.
Thank you all
Thank you so much.
panelists. Thank you.
Yeah, thank you, Anuja ma'am, and thank you everyone. And Kerala
Thank you.
sector. Neha ma'am, thank you for making me a part of it.
Pleasure, dear.
Pleasure. Thank you.
Thank you so much.
Thank you so much,
Good
ma'am.
night.
Thank you.
Yeah,
Bye.
bye.
Good night.
Bye.
Thank you, ma'am.
Gracie,
Thank you, madam.
You can see Madam Gracie Thomas. Thank you, madam. Thank you so much.
Thank you, madam.
Please
Sneha, all the best, Sneha. All the best.
Yes, ma'am. Please bless us also. I am contesting for the endoscopy committee chairperson.
Yeah.
Please kindly bless and support.
Yeah,
Okay.
sure, sure.
Thank
All the
you.
support from Cochin Society.
Thank you, madam. Thank you so
Thank you,
much. And good night. Bye-bye.
Signing off with very good memories and